Genomic sequencing is giving clinicians many new targets, but it's also sowing confusion. A return to basic biochemistry may be the answer. Mark Lemon of Yale School of Medicine made this point at the recent Oncology at the Limits conference in London.
Yeah, I think that the revolution really in sequencing of tumor genomes and whole exomes initially has really been quite spectacular. What's come out of it are a series of mutations in key targets that we can attack with the agents that we're discussing here. But what's happened as the mutations have grown is that there's tended to be a box-checking approach to the mutation. So if you see the mutation in the target, check the box for that target, and that will just suggest the agent to use. But of course, the mutations are changing the biochemistry of the system. And so if we really want to fully explore what's going on with this whole spectrum of mutations, we need to understand the biochemistry of the system. And so that's where our work really comes in, of drilling down into what are the consequences of these mutations for the actual oncogene products, and then tailoring the effects of those mutations to the drugs that we can use to inhibit them.
You actually made the point that there are too many mutations, and how does one decide which ones are relevant?
The early stages of identifying mutations has really led us to certain hotspots. And I think it's true to say at the moment that in EGF receptor and also in anaplastic lymphoma kinase, or ALK, that we work on quite a bit, if you look through the spectrum of mutations that are associated with different cancers, you can pick, in the case of EGF receptor, half a dozen or more. In the case of ALK, about 3 key hotspots where the mutations are activating. We understand, based upon the structures, how they're activating. But in addition to those hotspots, there's quite a lot of what many people consider to be noise. As you look at more and more tumors, more and more sequencing data, there are mutations in more and more patients. So the question really is, are those irrelevant? Should we just throw those away? Right now, I think, and at the beginning, I think it was fine to do that. But by the time we've been doing this for 20, 30 years, that noise is going to be thousands of patients. So we really, I think it's a necessity that we figure out which of those are actually activating but less common, and which of those are not activating. And so that's one of our key goals, is to try to develop ways when new mutations emerge in the clinic to be able to predict, based on our mechanistic understanding, which is really a structural understanding of how the molecules work, which of those mutations are actually going to be activating and therefore actionable.
Which of these EGFR inhibitory approaches looks the most promising?
With EGF receptor, there are a good set of agents out there, and if you understand the resistance that you're encountering, then, and you pick a drug right, I think there are good ways of overcoming it. Down the road, however, I think the way to advance here will be to identify additional approaches to countering resistance, because there will be more different ways that resistance arises. And so essentially, broadening the armamentarium, I think, is going to be the key. Allosteric inhibitors are being developed in some contexts. Those work slightly differently. We have the third generation cysteine-targeted agents. We have the original agents. We have wild-type specific covalent agents. There's a panoply of EGF receptor inhibitors and more to come. And I think that just using those smartly and probably or possibly in combinations will be the way, a good way forward. And that's just the intracellular targeting. In parallel, there's quite a lot of work targeting EGF receptor extracellularly with therapeutic antibodies.
You put forward some exciting developments in neuroblastoma. Can you describe the key findings there? So
yeah, with neuroblastoma, the goal there is to target ALK, or the anaplastic lymphoma kinase. And this is work we're doing with Yael Mosse, who's a close colleague and a pediatric oncologist at the Children's Hospital in Philadelphia. Now, ALK is an interesting story because there are really 2 ways in which it's linked to key cancers. One is in lung cancer, where crizotinib has been approved already. It was approved in 2011 by the FDA, where the kinase domain of ALK is fused to one of several different activating moieties, I suppose you'd call them, and you get a cytoplasmic kinase. In neuroblastoma, the situation is slightly different. It's the intact receptor tyrosine kinase that's in the membrane. And there are some interestingly different properties between the two of these. So crizotinib's working well in lung cancer with these fusion proteins I mentioned, and there's a development of several generations of ALK inhibitors there, and things are actually, I think, looking quite impressive. The latest drugs are actually a new Pfizer drug, which we call 922, is actually doing well at countering resistance there. In neuroblastoma, however, crizotinib really doesn't seem to work at all well. And one of the problems is that several of the, quote, hotspot mutations, as I mentioned earlier, are actually also mutations that bring with them resistance. So it's really quite an annoying situation in some ways that the activating mutations are also resistance mutations. So we've got to start off before we can do anything by addressing resistance. And in some ways, the way to think about resistance mutations if they occur in the kinase is that what they do is reduce the affinity of the drug. They're basically, you will increase the size of an amino acid side chain that will just occlude part of the drug binding site, so it has a harder time binding. The one way to overcome that is just simply make your drug bind much more tightly, and then it can take more hits before you get resistance. And I think that's the key with this new Pfizer drug, is that it binds probably 100, maybe 1,000-fold more tightly than crizotinib. And so you basically, in resistance mutations, have to be 100 or maybe 1,000 times more problematic for the drug to actually see the resistance emerge. So I'm quite excited about this. In lung cancer, it seems to be overcoming the key resistance mutations. And in neuroblastoma, I really feel quite confident that there'll be some useful, very valuable clinical results.
But don't we need to look beyond targeted therapy?
I think it's true to say that we generally believe that cancer is a signaling network disease, not a target disease. We're treating it as a target disease to some extent when we think about EGF receptor inhibitors, ALK inhibitors, and the like, but we need to just use those as a component of our approach to bring the network, the signaling network, back into a normal action. So actually one of the things in the Cancer Biology Institute that I'm building with Yossi Schlesinger at Yale, one of our key goals is to collaborate with systems people so that we can actually start considering cancer signaling as a system. And I think once we start doing that, we'll need quantitative computational approaches, because they'll be beyond my brain to really contemplate exactly what's going on. And so we'll really need to be modeling approaches to hitting multiple targets simultaneously to bring the system back and under control.